You know, it's really an honor for me. I'm not going to embarrass you, Michelle. It's really an honor for me to be able to have a former student come back and lecture to this class because there's really no greater honor that any professor or teacher can have is when the student becomes the teacher of the teacher. And so as I told you all 20 years ago, Dr. Evans sat in this class, but it wasn't this class. It was actually in Haynes 39, and it was a class of 300 students. And it was Life Sciences 3, but it was then called Biology 4B. And she tells the story quite nicely that the first day of class she showed up, and there was 300 people in the classroom. And of course I had the pictures of everybody, and I called people down and gave them the microphone, a little bit more primitive technology than it is today. And then on the Thursday lecture, Dr. Evans sat in the same seat and looked around, and instead of 300 people being in the class, there was only 100 left. But those 100 stuck with it, and I think had a reasonably good educational experience. In reality, I didn't meet Dr. Evans when she was in my class because in those days she didn't say very much. She was sort of quiet and shy like Rose. In any case, it wasn't until she needed a recommendation for medical school that she came running into my office after having about 5 cups of coffee at the Kirchhoff Center and asked me for a letter of recommendation, of which I said that I really didn't know her very well, and I only give letters of recommendations to students that I know. And in those days, believe it or not, that was 1990, 91, I think, I had probably about 1 second per day of free time for a variety of reasons. And so I said, well, I'd like to talk to you about, what your goals are. And so I generally run from 7 o'clock to 8 o'clock every single night. And if you want to join me, we can talk about, what your background is. And of course she said, yeah, I run. Little did I know afterwards that she had never ran before in her entire life. But the fact of the matter is it started a very, very long and very dear and close friendship. Michelle graduated from UCLA in 1991. And then she went on to medical school, graduating with very high honors. And I'm not going to go into all the awards and all the honors, but many of them were very, very special. And then she went on to do a residency, so 4 years of medical school, 4 years of residency, finished her residency as a OBGYN, board certified, and then went into private practice for a couple of years, delivered many, many, many babies, more than she can remember, spent many times in the hospital, all night long, and decided that what she really wanted to do, instead of delivering babies, she wanted to make babies. And so she went back and did a fellowship at the University of California, San Francisco, UCSF, in a very prestigious program in reproductive endocrinology, and graduated from that program and moved down to Los Angeles and is now in private practice with the Huntington Reproductive Center, which is the largest in vitro fertilization fertility center in Southern California. And so when you ask me all about the octuplets and all those things, you can ask Dr. Evans because she knows all about that stuff. But more than that, Michelle is really unique because along the way with medical school and along the way with residency and along the way with her fellowship and along the way with starting a very, very, very intense, time-demanding, independent, private medical career, she managed to have 3 beautiful children of her own, proving that one can have a very, very, very important and productive and exciting career and have a family. And so let's welcome back Dr. Michelle Evans and give her a round of applause. And she's going to talk to you today about fertility, a lot about fertility, in vitro fertilization, and genetic testing. Ask a lot of questions But before she begins, no stories about me, Michelle, please. Before she begins, we have a little bit of a surprise for you guys, so I'm going to turn it over to Dr. Evans.
Thank you very much. I'm totally embarrassed now. So I am going to, yeah. We're going to start actually, I'm going to talk to you today about, does this go into mine?
That was you. Oh, no, it's mine. Let me switch it.
Okay. I'm going to talk to you about infertility, in vitro fertilization. I'm going to talk to you about genetic testing before pregnancy, with pregnancy, and after. And what I'm going to do is just start with sort of my general day, and I'm going to have a couple come and visit me in my office and just go over a basic fertility consultation that I would have with them. And so I have my scheduled appointment, yes, 3:45, with Aicha and Tomo, who are coming to see me for their initial exam. So, and this is just basically what I do every day when I meet new patients. And I just want you just to listen carefully. Yeah, you can, or you can go wherever you want. Yeah, come on in. Right here, so you can say, okay, hi, nice to meet you. So we're going to just go over, you know, what I would talk about with them, and then just sort of listen carefully for things that you might think are important. And then we'll talk about a lot of these things during the class today. So it's nice to meet you.
Nice to meet you too.
So are you two wanting to have a pregnancy?
Yes.
Okay. Yeah. So tell me, you've been married for 3 years. I see that on your questionnaire.
Yes. Right.
How long have you been trying?
About a year.
You've been trying for about a year.
Yes.
And tell me, how are you trying? What are you doing?
Well, I have a series of Excel spreadsheets where I record my ovulation, my body temperature, and then when I'm ovulating, I put timers on both our iPhones so that it alerts us so that we know to attempt fertilization twice a day.
Oh, twice a day?
Yes.
Twice a day, 7 days a week.
Oh,
so
okay.
Exhausting.
Tomo, this isn't a game. We're trying to create life.
Well, we're supposed to have
Okay.
fun, right?
Isn't a Nintendo Wii, okay? Just please.
Okay, you know what I'd love to do is just go over both of your histories. And Aicha,
Okay.
I'm going to start with you, and then
Okay.
Tomo, I'm going to go on to you. Aicha, tell me how old you are.
29.
And what do you do?
I'm an X-ray technician.
Okay. And what type of x-rays do you perform?
Radiology.
Okay.
Yeah.
So just any kind of x-ray?
Yeah.
Work. Okay. And tell me about, how old were you when you first had a period?
12.
Okay. And are your periods regular?
They used to be, you know, they're pretty regular, like clockwork, and then about a year ago, they all of a sudden started totally getting kind of very irregular. I didn't really know when they were going to come, so I have it about every 2 or 3 months now.
Okay. And is the same number of days of bleeding that you've always had?
Yeah.
Okay. And do you bleed in between your periods?
No.
Do you have painful periods?
Yeah, they're really gnarly.
Really
Pretty
bad.
Yeah.
And have they always been like that?
Yeah.
Okay.
You know,
Did you used to miss school because of them?
Yeah, totally. You know,
Okay.
I take pills and stuff.
Okay. And when these periods started to get irregular, anything that you noticed that was different? Have you had anything like headaches?
I have had really bad headaches for about like 3 months or so.
Okay.
Yeah.
Have you increased your exercise at all?
No.
Okay. Do you notice any hair growth on your face or chest or anything like that?
I don't think so. No.
Have you noticed any leakage of milk from your breasts?
Yeah.
Yes.
Yes.
For how long?
For, I don't know, maybe 6 months or so.
Okay.
Yeah.
Okay. What about your medical history? Any medical problems I should know about?
Well, not really,
What
except
is that?
Any sexually transmitted
Well,
infections?
in college, after freshman year, I went on spring break, and when I got back, I had chlamydia, but it was totally cool. I went to the doctor, I took antibiotics, and then after spring break, my second year, I came back and I had herpes.
Okay.
But you know, whatever happens in Cabo stays in Cabo.
You told me you're a virgin.
Well, almost. You round down, Tomo.
So nothing besides those two things, huh?
Yeah.
Okay. Have you had surgery before?
No.
Do you take any medication?
Just, you know, Advil every now and then.
Okay. Do you drink?
Absolutely not.
Do you smoke?
No way.
Do you drink caffeinated beverages?
Yeah, you know, I have like a cup of coffee like every few hours just to keep me going.
Okay, okay. Tell me about your family's medical history.
Well, my mom had really early menopause about when she was 40.
Okay.
And then my sister was diagnosed with breast cancer about when she was 34, and then
Okay.
same with my aunt.
Okay. Both in their 30s.
Yes.
Okay. Okay, Toma, let's go on to you.
Yep.
Tell me how old you are.
I'm 32.
Okay. Do you have any children?
No, he doesn't.
Have you ever
No.
had a pregnancy with? Have you ever had a pregnancy
No.
with anyone?
No.
Well, maybe I should tell truth right now.
Oh, wait. Oh, what? Tio. What do you mean?
Long time ago, okay?
Who? With
Long
who? You
time
better
ago.
tell me who that was with.
Well, you don't want to know.
Just tell me right now.
Starts from K.
Who?
Kelly.
What?
Just accident,
You better meet me after class. Courtyard outside.
So you have had one pregnancy.
Oh, miscarriage. Though.
It miscarried.
Yeah.
Okay. Early
That's
first
right.
trimester or
Yeah.
miscarriage? Okay. And tell me what kind of work you do.
I'm a postdoc and working in a lab.
Okay.
So.
He's there all the time.
What? What
Well, I'm working, you know. I'm not-
are you exposed to chemicals or toxins in the lab?
I think so, like some chemicals and then radioactivity a little bit,
Okay.
and UV lights.
Okay. Do you have any significant medical history I should know about?
I think I was told that I had undescended testes.
Oh, okay.
Well, but they're on the right spots right now, so I think somehow it was fixed.
Okay.
But I don't know what happened.
Did you have a surgery when you were a child? Did your parents tell you about? Do you have incisions or scars that you can see, like in your groin?
Not that I know. Would you want to?
Well, maybe we'll look at that later.
Does she want to check?
Well, you know, she's a doctor.
Okay, so somehow they were inside and now they're
Right,
out.
right.
Okay, okay. What about do you smoke or chew tobacco?
I don't smoke, but well, I don't smoke.
He gets blazed like once a
Do
week.
you
Totally.
blazed? What? Tell.
Totally
I'm really
stoned.
Oh,
He thinks I don't know about it, but he keeps a stash
Okay.
under the mattress.
Normal.
Okay.
You know?
Okay, so you smoke marijuana
Once a week.
once a week. Okay, and do you smoke cigarettes?
No.
Do you drink alcohol?
Yeah.
How
Like
much?
the weekends,
Every-
three glasses of beer.
Okay, okay. So beer on the weekends, not during the week.
No.
No. And how about caffeine?
A little bit, just 1 cup a day.
1 cup a day, okay. And then tell me about your family history. Your mom, your dad, any illnesses?
My father had heart surgery, like
Okay.
just heart disease,
Okay.
and then my mother is diabetic.
Okay. And how about you said no change in exercise or anything for
No,
you.
not
Do you
for me.
exercise?
Yeah, I do a lot.
What do you do?
200 miles a week biking.
Wow. That is a lot.
Yeah.
Okay. Okay. Well, that's really helpful. That's a place where we're going to start. And we'll go on from here and kind of talk about our evaluation that we're going to do, and then we can decide what we need to do from here.
Thank you very
Okay,
much.
thank
Thank
you.
you.
Great. Okay. So that was a fast consult, actually, 5-minute consult. So that's what I do. I mean, every day, it takes about an hour, really. I mean, of course, we spend more time, and then we talk about our evaluation, and we talk about our treatment options, and we will talk about all of that today and during this lecture. We're going to start just with a couple of questions here, eye clickers. So do you have any friends or family members that have struggled with infertility? How does this work?
You just go start,
Okay.
and then you give them about 15 seconds.
Okay.
And then you go
So-
stop,
Okay.
and then you go display.
Okay, so, and then, okay, wait, so that, what is, A is what?
A is
Oh, A is
yes,
yes.
and
Okay,
B
so
is
30,
no.
okay, wow, so 37% of people in this class know somebody who has struggled with this, and 63% not. Okay, so that's a lot. Do you think that you are fertile? So, meaning if you wanted to have a pregnancy in the next 6 months to a year, do you think that you could? Wow. So anybody want to comment on that? You're sure, so.
How do you know? How do you know?
I'm not 100%.
You said that on the.
I said, do you think you are?
So Brian, how do you know? Do you have kids?
No.
I think there's only I think there's two people in this room that actually know. One of them is giving the lecture, and Amelia is sitting down in the back of the class. What about you, Dora? Did you say yes or no?
I said yes.
What about you, Faria? Did you say yes or no?
Yes.
How do you know?
I like to assume so.
Oh, and John's also fertile. There's three of you that are in this collective room. Okay, great.
So, I mean, you know, a great likelihood is that most people in this room are fertile, but there are a certain percentage of people that aren't, and we will go into that, what the percentages are. But people, you know, if they said, maybe I think I'm not, it might be people who don't have regular periods. It might be someone who has some strong family history that they know about. It may be someone in the class who knows that they have some chromosomes, maybe some people know that their chromosomes are different than other people and that they may not be fertile because of that. So, but so far we think 100%, that's good, hopefully. I hope you are. And what percentage of the population do you think is subfertile or infertile? Remember in the classroom we had, sorry, I got to start it, I'm not used to this. We had 37% of people that knew somebody that
Stop. Display. Woo.
Okay, so 7% saying 1 to 2%, and 5 to 10% was 23% of people, and then most of the people were right. So 10 to 15% of the population is infertile. It's a lot. I mean, it's tons of people that are infertile, if you consider how many people there are.
Hide.
Yeah.
Hide the thing.
Oh, hide. I've never used this before, sorry. Is that okay?
Yep.
Okay, so these are the things we're going to talk about today. We're going to talk about infertility in detail. We're going to talk about treatment options. And then we're going to talk about genetic testing, and then we can get into some things. There's a lot of controversial things that are going on. This is sort of like a perfect time for that with the octuplets being born. We can talk about some of those things. And then anytime you have a question, please just ask during this. Just stop me. Normal fertility, this is a little graph that shows you that if people are trying and they're fertile, about 85% to 90% of people will get pregnant in a year. Fertility rates are low. They're like 15% per month. So if you have 100 couples trying to have a pregnancy, only 15 of those couples will get pregnant in 1 month. So it actually takes time. It's normal for it to take time. Infertility is defined as 1 year of well-timed, unprotected intercourse without a pregnancy. And like we already talked about, 10 to 15% of the population is infertile. Okay, so what factors might cause problems with fertility? We have boxer shorts, drinking a glass of wine every day, eating disorders, hiking 30 minutes a day, history of yeast infections. Okay. And again, the biggest percentage that was for eating disorders, C, that was right. The other ones aren't related to infertility. Sometimes the tidy whitey shorts, those are sometimes because of heat. Drinking a glass of wine every day, actually that's not a bad thing to do as far as fertility is concerned. And drinking a lot though, for example, like binge drinking on a weekend is related to it. Eating disorders are, and significant weight loss in women in particular causes problems with ovulation and can cause infertility. Minimal kind of exercise or 30 minutes a day is fine, and yeast infections actually aren't. Chlamydia infections are. That was one of the things we talked about in our first consultation there. Okay, so causes of infertility. Infertility, there can be female causes, male causes, and then we also have about 30% female, about 30% is male. Then there's an overlap where you have sort of both male and female factors, and then you have unknown causes. And about 15 to 20% of couples that come in it's unknown reasons why. First thing we'll talk about is the female infertility. This is important when we're talking about infertility, is how do we make our eggs? Every month when a woman has a menstrual cycle, she is going to have a certain number of follicles on her ovaries. Follicles are small fluid collections that surround immature eggs. And there's just going to be a certain amount that we bring to the surface of our ovary every single month. we are going to produce from our pituitary gland right here, we're going to make follicle-stimulating hormone at the beginning of each menstrual cycle. It's going to stimulate all these little follicles right here, and only one of them will grow in a month, typically. And then it will be released, and it will make estrogen as it's growing, and then it will be released and ovulated, and then it can fertilize. All these other little follicles that we have every month will go away. Can't ever use them again. So we lose lots of eggs, thousands of eggs every single month. Causes of female infertility, we'll go over these. Anything from ovaries, tubes, the uterus, the cervix, hormones, and chromosomes. One of the biggest things that I see is female infertility from age-related factors. So I have a lot of people come into me when they're in their 40s, women in their 40s. They're saying, I really want to start a family now. I've been trying for a year to get pregnant and I can't. And so age is a huge issue. And then people can have problems with ovulation where they're just not ovulating normally. And people typically who have problems with ovulation don't have regular periods. And then people can also have premature ovarian failure where their ovaries just fail. They lose all their eggs at an early age. Okay, another question. Do women continue to produce eggs throughout their life from puberty until death? Yes or no? No, right. Right, so we are born with, I mean, this is really interesting, is that we have the most eggs in our ovaries when we're inside of our moms. So when we're 20 weeks gestation, so halfway through our mom's pregnancy, if we're a little girl growing inside, we had 4 million eggs in our ovaries. By the time we're born, we have 400,000 eggs left. By the time we go through puberty, we have 100,000 eggs left. And then by the time we go through menopause, they're gone. And the average age of menopause is 51. Fertility actually initially declines at the age of 27. Still great. People still have great fertility rates at 27, but that's when it starts to drop a little bit. And then it significantly declines at about 37 and a half. And then you see rare pregnancies after the age of 44. But you do see pregnancies, like if you read your People magazine, you see pregnancies when people are 49 and 54, and there's quadruplets right now in a 49-year-old with quads from the same doctor, the octuplet. And so, you know, people do, but those people are using donor eggs. So when you read those types of articles, it's important to say, you know, this really isn't their own eggs that they're using, and that our fertility is finite, and that's important. Yeah.
Where do the eggs go before puberty? Like, how do they leave?
They go through a process that's called apoptosis and atresia, where basically the eggs just sort of die inside and then they're reabsorbed by our body. These are...
IG, you have a question?
Yeah. Yeah.
So I heard a rumor. My friend's mom, who's a doctor, said that if you have your first pregnancy earlier, then you kind of, it's like easier for you to have your second pregnancy even if you're older than somebody who had never had a first pregnancy?
That's not true.
Okay.
That's not true, actually. But I mean, there's not a relationship there as far as you know, when the first one is and if you remain fertile. And also when you're pregnant, you're also, even though people aren't having a period, they're losing all those eggs every single month. So having pregnancies doesn't slow things down and give you like extra years of fertility. This is just some statistics about married women who are infertile, and as you can see with age, infertility increases, and a lot of that just has to do with the age of the egg, and that the egg is more unhealthy as we age. So as a woman ages, you can see that by about 40, we've got about half of our eggs that they're abnormal. They're just genetically abnormal. And these are from tests where they've taken eggs out of somebody's body and they've just tested them and seen how many are normal and how many aren't chromosomally. And then by the time we're 42, you know, majority of them, 45, almost all of them are abnormal. And the next thing we'll talk about is ovulation. This is just an example of a normal menstrual cycle where this pink up here is the uterine lining that sloughs off when somebody has a period. It gets really thin. As the egg starts to grow here, the uterine lining gets nice and thick because it wants a pregnancy to implant in there. The little egg is released. And then there's a chance here for this egg to get fertilized and implant into the uterus. And if a pregnancy doesn't occur, then the uterine lining sloughs off again. Somebody has a new period starts, FSH is secreted again to make the eggs grow. So why would people not ovulate normally. And usually there are a good sort of a percentage of women at your age who would not have normal menstrual cycles. They'd say, no, it doesn't really come every month, maybe every 2 months, 3 months. Some people might say, I don't ever have period, it comes every year, something like that. There are different reasons for that. One is hormone imbalances. There can be imbalances in hormones like thyroid hormone, prolactin hormone that comes from the pituitary. Weight changes can significantly impact ovulation. So if somebody is overweight, they can stop ovulating because they make too much estrogen out in their fatty tissues. If they're very thin, they can stop because they don't get a good signal from their pituitary gland anymore. And stress can play a role. If somebody has something very stressful happen to them, someone dies in their family, something like that, they can stop having periods for months. And so this is one of the, the things that I would see in some of the patients that come in. Premature ovarian failure is someone who goes through menopause before the age of 40. Normal menopause, I said, is about 51 in the United States. What we see in these women is you see just very decreased estrogen levels when we check because they're not making estrogen. They don't have eggs left in their ovaries. They have very high FSH levels because our body will continue to pour out FSH even if we don't have eggs. It's like it just wants to make the eggs grow. So even when we go through menopause, we're going to have high levels of FSH trying to make these eggs grow, even when they're not there. The causes of premature ovarian failure can be autoimmune. It is associated with autoimmune diseases like thyroid disease. It can be genetic, and we will see it running in some families, or idiopathic, which just means we don't know why people have it. Still, about 1% to 2% of people who have premature ovarian failure could have a spontaneous pregnancy. But most people who have this, if they want to have a child, would have to use a donor egg if they wanted to carry a pregnancy. Okay, next thing we're going to talk about is tubes, so fallopian tubes. So once somebody releases an egg, then the egg is picked up by their fallopian tube, and the fallopian tube is where egg and sperm are going to meet and fertilize. So here, what factor would not cause a woman's fallopian tubes to be blocked? Diabetes, ruptured appendix, endometriosis, chlamydia infection, or tubal ligation? Tubal ligation is when somebody has their tubes tied. Endometriosis is something where people have very, very painful periods. That's one of the things I was asking her about. And they actually have uterine glands that get outside of their uterus. And when they have a period, they actually have bleeding inside of their pelvis. That's what causes pain. Okay. Okay, so what factor would not cause a woman's fallopian tubes to be blocked? The one on there that really doesn't have any association is diabetes, and 39% said that. Ruptured appendix can make people's tubes block because the appendix is near the tubes. If an appendix ruptures, that means a bacterial infection spreads through the pelvis and it can close the tubes. Endometriosis, like I said, people have bleeding in their pelvis, it can block their tubes. Chlamydia infection is the one that's big and known for blocking tubes, and it's usually asymptomatic. 80% of women who have a chlamydia infection don't know that they have it. And then a tubal ligation, of course, the woman who wanted to tie her tubes after having pregnancies. Okay. Okay, so we talked about some of those things already. This is not the best picture, but when we do our evaluation, one of the things we talk about is eggs. Okay, after I talk with a couple, we talk about eggs and what role they have. We talk about fallopian tubes and their role. And the test that we do to see if someone's fallopian tubes are open is called a hysterosalpingogram. It's an X-ray test. That's what this is. And it's an X-ray test where we put dye through a woman's uterus and through her tubes, and we see if the dye spills out the end of the tubes. This is the uterus, this little triangle. This little thing that looks sort of like spaghetti right here, that's a tube. And then this right here, this round part, that's a tube. This is actually dye spilling out of this tube, and this is a little bit of dye spilling out of this tube. So this is normal. This person has open tubes. This person, this is again the uterus. See these big fat tubes? So they don't look like little spaghetti, they look like sausages kind of. And they are blocked. And so when we put the dye through, you just get this big distended fallopian tube, and then nothing spills out the end of the tube. So that person has blocked tubes. So the egg and sperm can't get together in somebody like that. Another thing that we look at besides tubes is the uterus.
So Michelle, what do you do when the tubes are blocked? Can you go back?
Yeah.
Let's say someone has that diagnosis. What do you do?
So when the tubes are blocked, your two options are to do a tubal repair. So we would go in and do a big surgery and try to open up the ends of their tubes. And it's really not very successful. It works for some people, but it usually doesn't because the tubes are really fragile. They're really friable on the ends. And so when you operate on them and try to open them, they have a really big tendency just to close up again. That's one option, not a great option. The other option is to do in vitro fertilization, and that's a great option for this, where you take eggs out of somebody's body, put them together with sperm in a dish in the lab, embryos are formed, and then basically the lab acts like the tube, because embryos will be in a fallopian tube for 3 days after fertilization occurs before they'll move into someone's uterus. So we keep them in the lab for 3 days. When it would have moved into the woman's uterus, we put it into her uterus. So we just take a little catheter and we put it back up into her uterus. When people have big blocked ones like this where they're swollen, it's actually recommended to remove the person's fallopian tubes before they have in vitro fertilization. So we go in and do a procedure called a laparoscopy, where we go in through the belly button with a camera, take their tubes out, and then do the procedure. And that's because you actually have a 50% decreased pregnancy rate with IVF, with in vitro fertilization, if you have big tubes like that. It's probably from fluid that's washing back into your uterus and washing embryos out. Okay. Other things we look for, uterus is really important. Obviously, you need a normal uterus or a healthy uterus to have a pregnancy implant and grow. People can have fibroids or polyps in their uterus, and this is an example of a fibroid. About 20 to 25%, actually 25 to 30% of women have fibroids. They're just muscle growths. It's smooth muscle, which all of this uterus right here is smooth muscle, but these are these abnormal smooth muscle growths. They are benign most of the time, but they can cause problems with fertility, because if a little pregnancy tries to come in here and implant right here, and it starts to grow and wants to invade into the wall here, it's going to hit into this fibroid, and it's probably not going to grow well, might miscarry, might not implant. This again, remember, this is that same picture we looked at. This is now looking at the uterus. This is a really normal uterus, and this is a uterus with fibroids in it. This right here, see this where the dye isn't filling? That's a fibroid. There's a fibroid here, pushing in the top, and there's actually a fibroid here, and this fallopian tube's going over the top of the fibroid. So that, if somebody has a fibroid, we remove it. So if it's a fibroid that we think is affecting implantation or growth of an embryo, we would remove it. It could be removed if it's right inside the uterus. We could actually go through the cervix and remove it that way. If it's big fibroids all throughout their uterus, we'd actually go in with like a kind of C-section cut with an open surgery and take the fibroids out. People can also have polyps, which are just soft little growths inside of their uterus. We would remove those, just usually going through the cervix. And then people can have congenital anomalies. So when a little female fetus is growing, we actually all have 2 uteri when we're growing inside of our moms. So it grows kind of one on each side. What happens as we grow is that then the 2 uteri fuse in the middle. So then we have 2 still, but they kind of look like one on the outside. And then before we're born, this part where they fused in the middle, this septum, it reabsorbs. So by the time we're born, we have 1 uterus and just 1 cavity. But sometimes things stop in the middle. Sometimes people get to this point, and that's where they stay. So they actually have 2. Sometimes people have 2 of everything. Sometimes people have 2 uterus, 2 cervix, 2 vaginas. Sometimes people have no uterus, but they have ovaries. So all sorts of different things can happen, and we definitely see that. This is an example of yeah.
Go ahead.
Yeah, this is an example of somebody who's got a bicornuate uterus. They have 2. Do you have a question?
What the 2 things, if you go back. One is, what percent of the patients that you see have tumors in their uteri that you happen to find that they didn't know were there?
I would say probably at 20%.
And what could be the consequence of cancer of the uterus?
Really rare, actually. So with the things that I usually see, usually I'm seeing women who are in their, probably at the oldest about 50. And most of the things that I find in someone's uterus are benign. So almost all polyps are benign. More than 95% of what looks like fibroids are benign. And so if we don't think they're affecting their fertility, we usually leave them inside. They're not causing anybody a problem. If we think they are affecting pregnancy, then we remove them. And I usually don't see cancerous tumors. Now, I do see women who don't ovulate. So these women who say, I have a period once a year, that person is a setup actually for a uterine cancer, because they are not sloughing off the lining of their uterus. It's just sitting there, and that's a really bad thing. And especially somebody who would, let's say, is obese and doesn't ovulate, that's even worse because they're getting a lot of estrogen to their uterus, and it's a precursor for a uterine cancer. So I actually do see that. Okay, so like I said, we can treat with hysteroscopy. Hysteroscopy is where we go in with this little camera through the cervix and into the uterus, and we might remove like a little polyp that's sitting inside here, a little fibroid that's right here. And we can also do surgery with laparoscopy, where we go through the belly button, and we can take things out that way, or we can just do a sort of traditional surgery. Yeah?
Okay, so I just have a really quick
Your
question.
mic on, Samantha.
It's on.
Yeah.
So my one question is, you were just talking about if you don't shed your endometrium, it's very unhealthy.
Yes.
What about these birth controls that are keeping women that they only have a period maybe 4 times
Those
a
are
year?
great. Those, yeah, so that's different.
Is that
The thing that's
unhealthy?
different about it is, and somebody who, let's say somebody who comes to me and says, you know, I don't have a period at all. One option, but I like it. You know, I have a period once a year and it's great. That's okay. It's okay not to have a period as long as you keep the uterine lining thin. That's the key. So a birth control pill has progesterone in it and estrogen in it. Progesterone is the thing, so if someone doesn't have a period for a year normally, it's because they're not ovulating. When you don't ovulate, you don't make progesterone. So when you don't release an egg, you don't make progesterone. And progesterone is the thing that's going to allow someone to have a period, or it's going to allow their uterine lining to stay thin. On a birth control pill, continuously, estrogen and progesterone, you're actually always keeping a thin lining. That's why you're not bleeding. So that's not a bad thing. And as far as we know from these continuous birth control pills, that's fine. The uterine lining stays thin. When I see people on continuous birth control pills and I do an ultrasound, their uterine lining's really nice and thin. Yeah, so they shouldn't have a risk factor. They shouldn't have a risk for a uterine
Julie,
cancer.
microphone.
That's a good question.
Julie, over here, on your right.
Yeah.
To follow up on that, is there any advantage over using a contraceptive where you ovulate or where you have a period every month versus every 4 months versus every year?
Not really. As far as future fertility, you mean? Or just in general? Are you saying, I mean, does it matter if you use...
With cancer, if you have a thicker lining, or is it just
No.
consistent throughout all of them?
No, it's actually okay. So if you're using a contraceptive where you have a period every month, or you're using one like a continuous birth control pill, or you're using like, let's say, an IUD that has hormones in it so you don't have a period while you have the IUD in there, any of those are fine. There's not an advantage. And it really just with the contraception for contraceptive effect, most important thing is to use it correctly. And as far as future fertility, none of those things are going to cause problems with future fertility or cancer. Yeah.
Michelle, while we're on that topic, can you tell them the percentage of pregnancies that they get while on contraceptives?
Well, if it's used correctly, it's really small. So, I mean, if, for example, an IUD has a less than 1% chance of pregnancy, an oral contraceptive, really, if people were using it just right, it would be about 1% also, but it's about 3% pregnancy rate with that. And then tubal ligation, still, people can get pregnant after having their tubes tied.
What about condoms?
Condoms aren't that great. I mean, they're good, but they're not, you know, their percentages aren't as good, and that just has to do with use, breakage, you know, that type of thing. But they're still, the pregnancy rates are still, you know, should be less than 10 to 15%.
Watch out, guys.
If you, so I do see women who don't have a uterus. So I might see a woman who comes in, she's 19 years old, and she says, you know, I don't know, I've had just sort of normal development and everything. I have, you know, breasts and everything, but I just have never had a period. And she may not have a uterus. So that is something that, and we'll talk about it a little bit more later. Or, you know, I might see somebody who had to have some emergency surgery and a hysterectomy when they were young and they want to have a baby. So for people who don't have a uterus for one reason or another, you know, using a surrogate mother is one option where they could use their own eggs, have someone else carry the pregnancy for them. We'll talk more about that. Just briefly, cervix, I mean, people can have something going on with their cervix that causes infertility, like they've had an abnormal pap smear. Because of their abnormal pap smear, they had part of their cervix removed with a surgical procedure to get rid of those precancerous or cancerous cells, and now their cervix is closed. You know, maybe sperm can't go through it that well. The cervical mucus glands may be gone, and that cervical mucus is something that pulls the sperm up where it's supposed to go, and so there may be some issues with the cervix. That's pretty rare.
Yeah.
Yeah.
You know what a cervix is?
Are you talking about me?
Do you know what one is?
Yeah.
What is it?
It's a small passageway between the vagina and the uterus.
Excellent.
Yeah, so it's actually the bottom part of the uterus. It's the very bottom part of the uterus. Yeah, that's good. Gosh, that's a lot of pressure to know what that is. Geez. And then finally, some people can have chromosome abnormalities that lead to infertility. Women can have something called Turner syndrome, where a woman with a normal chromosome number has 2 X chromosomes. People can be born with 1 X, so they're missing their second sex chromosome. They are women. They are very short, typically. They have very specific kind of body things that you'll see on a physical exam. You'll see typically a webbed neck. People will be less than 5 feet tall. They have kind of a broad chest. They have really wide-spaced nipples. There's a lot of different things that people have who have Turner syndrome. But normally what people who have Turner syndrome also have ovaries that lose their eggs really fast because they only have 1 X chromosome. And it's rare for someone with Turner syndrome to have a pregnancy. Androgen insensitivity is someone who looks like a woman but has XY chromosomes. The most well-known person who has it is Jamie Lee Curtis, has androgen insensitivity. So she actually has an X chromosome and a Y chromosome. She looks just like a woman. She actually had testes when she was born. They never moved down where they were supposed to. They were removed. They're typically removed after the person goes through puberty because they can turn into testicular tumors. And people who have androgen sensitivity don't have ovaries, won't be able to have children. And anyway, but they look very much like a woman. Okay, so then we're done with the female fertility. So we have sperm. We need sperm to have a pregnancy. So do men continue to produce sperm through their lifetime? Yeah. Yes, they do. They do. Things will, there's certain parameters in a semen analysis that will.
Stop it, Michelle.
Oh, sorry. There are certain parts with sperm, like motility and morphology of sperm, that will decrease over time, but men do continue to produce sperm. And there have been people like, I think, what Charlie Chaplin was like in his 80s or something like that when he had, or 90 or something, when he had a child. So male infertility can be caused by problems with sperm production, sperm function, or an obstruction in the ductal system, which is how the sperm gets out of the body. So just a real brief little biology class here. Sperm is produced in the testicle. It is stored in this little thing called the epididymis right here. It gets out of your body through this tube that's called the vas deferens, and when someone has a vasectomy, this is the tube that's tied and cut so that the sperm can't get from the testicle to out of the body anymore. And then when there's this little thing called seminal vesicle, some fluid comes in with the sperm here. This is the prostate gland. More fluid comes in with the sperm here, and then basically the sperm goes out this way through the urethra and out to the outside. So that's when we talk about obstruction, it's obstruction along that tube system. So when a couple comes to see me, we have already talked about the female evaluation. We're going to evaluate her eggs. We're going to evaluate her tubes and her uterus. With the man, we're going to evaluate him with a good history, and a semen analysis. So when somebody gives a semen analysis, they basically just give us a sperm sample in a cup. We look at it, and we see if it's normal. Normal would be greater than 2 cc's of ejaculate. Concentration more than 20 million sperm per milliliter. More than half of them should be moving well. And then they should have a normal morphology. That's just their shape, the way that they're shaped, their head, their midpiece, and their tail. This is actually the criteria that we use in our office. It's called a Kruger strict criteria for morphology. Normal is 14%. So you can see that it's normal not to have a lot of normal sperm, basically. But if people have a very low Kruger strict morphology, less than 4%, we really find that fertilization doesn't occur well at all. And so we do special techniques to make egg and sperm fertilize. So here's some sperm. These are normal. So this is a normal head. This little part right here is what we call the midpiece, and then there's the tail. And most of these sperm on here are very normal looking. And then these are some abnormal ones. This is two-headed, little pinhead, taper head. Big mid pieces right here, broken tails, little holes in their heads. So lots of sperm problems. So how many sperm do you need? So if you're just at home wanting to have a pregnancy, how many sperm do you need to have a pregnancy? You need about 20 million sperm. in an ejaculate. If you're going to do an intrauterine insemination in the office with me, where you're going to give a sperm sample, I'm going to wash the sperm and process it, and I'm going to put the sperm up inside the woman's uterus. We need at least, this is really low actually, we usually like 10 million, but you could have as low as 1 million sperm. With in vitro fertilization, where the eggs and sperm are put together outside of the body in a dish, we put about 10, we can have as few as 10,000 sperm. Honestly, we usually put about 100,000 sperm with the eggs. And then when we do ICSI, which is where we take a single sperm and inject it into the egg, we only need 1 sperm. Yes?
Since there are like so many sperm in a sample, how are you able to visualize all of them to check for abnormalities?
You can't. It takes a long time actually to do this Kruger-Strict morphology test, and I think that's why probably a lot of labs don't do it. But we'll actually look at just a certain portion of them. We'll look at many fields, and it takes a long time. It takes us a few days actually to do the counting to see what percentage of them are normal. We'll actually fix it. We'll fix the specimen and look at it. We basically look at high-power fields.
Is this the same stuff they look at if you were to donate sperm?
Yeah, they're going to look at, the things that they're going to look at really are the volume and the count and the motility. They're not going to focus very much on morphology for a sperm donor. They just want to know, is there enough there? Is it moving well? Yeah. Okay, so people can have a decreased production of sperm. So there are some men that I see who give their sperm sample and they have no sperm. So they do have an ejaculate and there's nothing in it except fluid. So that's called azospermia. Or people can have what's called oligospermia, which is not very much sperm, where they might have 1 to 5 million sperm instead of the 20 million sperm per milliliter. And the reasons why people might have that, one reason is genetic reasons, like a deletion, a microdeletion on the Y chromosome. And I know you've talked about Y chromosomes and the SRY region and all that. That's the region that it would be in, and people have these little tiny deletions there. And certain deletions, even though we see no sperm in the ejaculate, we know we can get sperm out of their testes if we want to. And other deletions, we know that we're not likely to find sperm anywhere. And people can have damage to their testes. Cryptorchidism, that's kind of what we talked about in our initial thing with Tomo. That's an undescended testes where people are born like with one or both testes up inside their body. They haven't come down like they're supposed to. So for a boy, when he's growing inside, the testes are up inside. And then before you're born, they're going to come out. They're going to move down through the abdomen, through the inguinal region, and out into the scrotum. In some boys, they don't. And sometimes that can cause a problem when they're inside, because they are they're in a hot environment. It's different. Sperm don't grow well there. People can have them brought down through a surgical procedure, but sometimes still they don't work very well after they're brought down. Varicoceles are basically like varicose veins in the testes, and it just makes it really hot in the testes, having all that increased blood flow there, and it can cause problems with sperm production and motility. People can get infections, and this is the big one, is mumps during puberty. So if someone had mumps when they go through puberty, they may have no sperm. And then toxins like chemotherapy, radiation, something like that, where the sperm is used to be there, but now it's gone. Then sperm function. The sperm has to function well. It has to move well to get to the egg. Some men have antibodies on their sperm, and so it just doesn't move that well. It's kind of sluggish, has the antibodies stuck to it. It kind of makes it heavier. It doesn't move well. There are things we can do, washing sperm or taking single sperm and putting them into the eggs so that fertilization can still happen. If people have infections, like in the prostate or that type of thing with increased white blood cells, that can cause a problem, so we'd want to use antibiotics. This varicocele with the sort of varicose veins in the testes, we can do varicocele repairs. They don't work that well, but some people, they'll help their sperm count and sperm motility. Or we can do other treatments like inseminations, in vitro fertilization. The sperm head has to, once it attaches to the egg, it has to open up and release enzymes to get through the egg. It's called an acrosome reaction, and some sperm don't do that. And then other sperm might have problems with binding or penetration, usually because they're a weird shape. And then obstruction. So we talked about that vas deferens, where the sperm needs to go through. People could have a vasectomy done, and so that's obstructed now. It's closed. I mean, that was their choice, but some people want to have a baby after their vasectomy. Some people are born without the vas deferens tubes, where both sides are gone. That actually has it's significantly associated with a disease called cystic fibrosis. that people can have this congenital absence of their vas deferens, or you can have blockages along the way. All those parts I showed you with that tube, it could be blocked anywhere along there. Okay, so what percentage of men desire another pregnancy after having a vasectomy? Okay, so the most we said was 10%. Actually, it's 5%. So about 5% of men after having a vasectomy will come in and want to have a vasectomy reversal or want to have another baby. Okay, and then lifestyle things. These are things that can cause problems with the semen analysis. Tobacco, that's one of the biggest ones, is smoking cigarettes. Marijuana can. Alcohol, but like I said, it's more like really kind of heavy binge. It's sort of like party drinking on the weekends, big alcohol on the weekends. Cocaine can, if people take steroids, it can actually permanently damage the sperm production. Heat, that can, like the varicocele we talked about, hot tubs, Tomo, and then exercise. Actually, exercise like long distance bike riding is known to affect sperm production. It probably has more to do with actually just somebody's testicles hitting the bike seat, sitting on, it's sort of like that type of thing. But the thing is, most of these, except for the steroid sometimes, if you stop doing these things, the sperm is fine. So, and it takes about 69 to 72 days for totally new sperm production. So if somebody wanted to have a baby, but they come in and they say, oh, I smoke 2 packs of cigarettes a day and whatever, we say, you know what, why don't you stop doing that if you can, and we'll recheck a semen analysis in 3 months. And a lot of times you just see that the semen analysis goes from being abnormal to normal from taking away some sort of something you do. Okay, so we talked about what we'd want to do. We're going to check for if the person's ovulating. We're going to check egg quality, which we can do with blood work and an ultrasound. We're going to do the semen analysis. We're going to do this hysterosalpingogram to look at the tubes. About 80% of people will find something on this basic fertility evaluation, and it will guide us in how, where we should go from there. And about 15 to 20% of people will find nothing. But the interesting thing is in those 15 to 20% of people who've been trying for at least a year to have a pregnancy, and we do their entire evaluation and their evaluation is negative, their pregnancy rate, if they were just to go home and just keep trying, their pregnancy rate's about 2 to 4% per month compared to 15, which is normal. So there probably is something going on, but we just don't know how to, we don't know how to detect it or what to test for. So there are things we can do. So different types of treatment options. One is just to talk about, what are you doing? How are you timing things? So these guys were just having sex way too much. So they were waiting for, looking around ovulation time, and then they were having intercourse twice a day. It's actually a lot because you don't get a lot of sperm. If you're having sex all the time, not a lot of sperm gets there each time. So we talk about timing. We talk about trying to get sperm closer to the egg before ovulation occurs. So basically the goal here in timing things is you want sperm there early, a couple of days before ovulation, and you want sperm there all the time. And the best way to do that is to start a few days before ovulation and every other day. So that's one thing. So sometimes that helps, just talking to people about timing, and they time things differently, and then the next time you talk to them, they're pregnant. And most of the time that doesn't help that much. And there are different things we can do. So one thing we can do is doing inseminations. Another thing we can do is doing in vitro fertilization. So inseminations is where we, where I said a man would give a sperm sample. We would wash away all the dead sperm and all the seminal fluid. We would get only the moving sperm, the good moving sperm, and we would put the sperm into the uterus. So normally, right, the sperm's just going to be in the vagina, and it's going to have to go through the cervix, through the uterus, out into the tubes. And this way we put it right here at the top of the uterus, and it can go right out into the tubes. So basically it's just trying to get sperm closer to tubes. It's trying to bypass any factor in the cervix or vagina that may be slowing the sperm down or stopping it. So it has to do with proximity. So that's one thing we can do, is just try to get the sperm closer. This is something that we do for people, let's say a single woman who comes in and says, I don't have a partner, I want to use donor sperm and get pregnant. We don't need to use medicine and do all sorts of crazy stuff. We can just say, okay, when you call me when you're going to ovulate, and then they can come in and we can do an insemination just to get sperm there. Yeah.
Is that a very invasive procedure, per se?
It's not really invasive. It is, I mean, it's invasive in terms of, yes, we are taking a little catheter that's actually going through the cervix, so someone is having something introduced into their body that normally wouldn't be, but it's got a very low chance of any kind of problems, a very low chance of infection or any complication. And it's kind of like, I mean, for any woman who's had a pap smear done, it's just kind of like having a pap smear done. It's not painful. I mean, not any more uncomfortable than that. Okay, so we can do inseminations alone, or we can add medicines to inseminations. And the goal of adding medicines is we're going to give the woman medicine to make more than one egg grow in a month. So normally, let's say she releases 1. We're going to give her medicine so she'll release 2, or maybe she'll release 3. We're going to combine that with an insemination. So what we're trying to do here is just get more eggs and more sperm together. And so here, you can see pregnancy rates per cycle. This is just using insemination alone, and this is in a group of people with this unexplained infertility, that 15 to 20% of people. It's not that great just using insemination alone. If we use just, this is an injectable medicine for a woman. If we use that alone, bumps it up a little bit, it's still not that great. But if we combine the two, you can actually get really pretty good pregnancy rates. The way that the medicines work, we have 2 medicines we can use. We can use an oral medicine that's called Clomid. That's the simplest thing we can do. Clomid is a medicine that makes a person's body think that it's low in estrogen. So it's actually an anti-estrogen, so your pituitary doesn't get as much feedback, and your pituitary gland will then put out more FSH. It'll put out more follicle-stimulating hormone, and usually people make 2 eggs or 3 eggs when they use Clomid. And the other option is to use follicle-stimulating hormone. So we can actually give people the same hormone in an injectable form that their own pituitary makes. And when we do that, people usually make more eggs. And this is what we use for in vitro fertilization. This is also what we use for some insemination cycles. But usually people will make multiple eggs with this. 3 eggs, 4 eggs, 20 eggs, 40 eggs. Just depends on the person. And when I heard about these octuplets, I was sure it was this. I was like, oh, you know, they used this. She made tons of eggs. They did an insemination. And it wasn't. But that's usually where you'll see a high-order multiple pregnancy like that, is from using an injection. A woman makes a ton of eggs on her ovaries. You go ahead and do an insemination, and then everything fertilizes. So it's typically that type of thing. Okay, and then we'll talk about in vitro fertilization. And in vitro fertilization, like I said, is where we take eggs out of the body, we put them together with sperm in the laboratory, and then we make embryos and put them into the uterus, and we hopefully don't get that many babies to come out. Hopefully 1. So who needs in vitro fertilization? People who are infertile may need in vitro fertilization. We might do their initial workup and find out that the tubes are blocked. We might do the initial workup and find out that there's no sperm coming out, but that we could get sperm from the testicle. And if you only have a little bit of sperm, you need to do in vitro fertilization to make fertilization take place. We might use in vitro fertilization for people who know that they have a genetic disorder that runs in their family, and they want to have their embryos tested and make sure they put in embryos that don't have that disease, like Huntington's disease or something. People might use it for gender selection. That's controversial. They may come in and say, you know, I have 2 girls and we really want a boy. So you could do in vitro fertilization. You could test their embryos and just put back boys. Non-traditional lifestyle. I mean, this is basically like couples who come in, maybe a gay couple, 2 men. They want to have a baby. They need eggs from somebody. So someone's going to have to go through in vitro fertilization, have the eggs, you know, take the eggs out, and then maybe they'll put their sperm, combine their sperm together, put them together with the embryo, make a baby. Or let's say that a lesbian couple came in and they wanted to take her eggs, but then put the embryo in her uterus so that they both have that connection to the baby. So those are things you have to do outside of somebody's body, just for a few days at least. Yeah?
Just how often does the gender selection actually, how often is that like actually requested?
Not that often. Not that often. And it's typically not, at least most centers don't offer it to people who have not had children. It's for balancing families. It's not for someone who just comes in and says, you know, I just really want a girl or a boy. It's sort of just to try to balance things. And it really, that's probably the very, you know, very few people want it. Okay, so this is a big important question from these octuplets. A lot of people are talking about who should decide if a couple or a person can have fertility treatment. Should it be our government, our national fertility agencies. We do have agencies that recommend how many embryos to put back, and we'll talk about that. Should it be a reproductive specialist like me who decides who can have treatment? Should it be a psychologist or a psychiatrist that evaluates the couple or person, or should it just be the person? Okay, there's no answer to this really. I just wonder what you think, because that's the big question that's coming up now is, should somebody have done something about this lady who had 6 children already? Is it okay that she was going to have more children? Whose decision was that? And, you know, most people think it's mine. I don't. I don't really think it is my decision, because people are going to make decisions about what they want, you know, how many children they want, what they want to do. No one's going to be telling them what to do if they're able to get pregnant at home. No one can say, you can't have 12 children, you know. That's their choice. So I don't, you know, really, I don't at least feel like it's my decision. I think it's the person's decision. But we'll see what will come out of this case, and if there will be sort of, you know, more strict guidelines about that. Okay, and then so only the 38% thought the person should decide. Okay. Okay, how about this one? Should a 52-year-old postmenopausal woman be able to use her daughter's egg to have a child with her new 28-year-old husband? Yeah. These things really happen. These, she was gonna be in big trouble if she didn't agree. Oh, wait, did I just? Okay, sorry. Okay, yeah, okay, so that's split. Yes, she should be able to. No, she shouldn't. And there's no answer to that either. That's just, you know, that's really up to each. I mean, basically these types of things, and we see all kinds of things. It's really, these things are up to the doctor and the person to decide, you know, if they think that this is okay, if they don't think this is okay. I mean, at least a physician, if you're going to refuse service to somebody, you should be able to then refer them to somebody who can help them with their, whatever they want. Okay. How about this? Should a woman be able to have sperm extracted from her husband's newly dead body so that she can have their child?
This is real stuff.
This is real stuff. So most people, well, majority, about, you know, 2/3 thought, no, that's kind of ew. But these are requests that people make. We've had requests when I was up at UC San Francisco from a man's parents. When he died, he died late at night up in San Francisco, and was a young man, and they wanted his sperm, their son. They wanted a grandchild. So, you know, people want interesting things.
Who said no? Tiger, what was your reason?
Because they don't have consent from the man.
I think that's a good point.
I think, like, in the preceding case, like, both of these cases are kind of gross, but but in the preceding case, like, the mother and her, like, new husband and the young woman all are there to be able to give consent. So, like, if they want to do that with their bodies, they, I guess, should be able to. But here, he doesn't have any say in the matter.
Who said yes? What did you say, Dora?
I said no.
Faria?
I said no too.
Who said yes? How about Rose?
To answer to what Tiger said in terms of the man not having a say in it, he's also dead, so it doesn't actually matter that he doesn't have a say in it. You know what I mean? Like, the fact that this baby is going to be no different than if it was just a sperm donor sort of thing. So, I mean, why not? I mean, it might be icky, but sperm donors choose to donate their sperm, but like the dead husband, they don't have any, like, it doesn't matter. They're never going to meet the child. They're never going to see the child. So it's basically the same. Like, it's icky, yes, but, I mean, if the woman really wants it, go ahead.
Albert, do you have a question?
Like, this could lead to people just, like, getting a bunch of dead bodies, being like, I want this kid's sperm, and they're like, I want this dude's sperm, and like that's really messed up.
Remember, this is something that needs to be done when he's freshly dead.
I mean, like people
He's
die
got to
all
be
the,
like
people die
warm
all
dead.
The time, though. Like.
So it's going to be
and
some.
You're saying like he's dead, so like you don't need dead person's consent. All right, so you take any dead person that just died and be like, I want their sperm. And,
Yeah.
like,
Right.
Max,
Remember,
you have a
this is,
question?
well, at least in this one case, when I was in San Francisco, it was his family. It wasn't just anybody saying we want his sperm. And, oh, he looks good. I want his sperm. But it really, you know, that case, we actually, our urologist that we work with did come in. He did the case at like midnight. He extracted sperm from the guy, he froze it. And then it turned into a huge legal battle. Huge. Afterward.
Max, you have a question?
It was family.
Hold off,
He had a wife, but it was the parents that wanted it, and then he had a wife, and you know it just turned into it. And I don't ever think, at least by the time I left there, it wasn't settled. Nothing was settled, and the sperm was just kind of still there. Is it going to be thrown away? Is it going to be used? So yeah.
Max.
So yeah, how healthy is the sperm after death? I mean,
It's freshly fine.
Oh, okay.
As long as you're warm still, it's fine. You can take it out and freeze it, just like you kind of do with the sperm donor. Yeah. So. Okay, creepy. So a little bit of history of in vitro.
Eric, do you have a question?
Yeah. Yeah.
Does freezing it not damage it though?
Actually, freezing's okay, and that's one of the things we'll talk about. But freezing sperm. So if somebody's a sperm donor, that's what they do. The cryobank, like California Cryobank, you know, gets all these young guys to donate their sperm. Freeze them there. People go through a catalog, pick out. They're like, oh, okay, that guy, like him, he went to UCLA, and you know, and they pick them, and it can be frozen there for years. We do the same thing with embryos, and we'll talk about that. You know, we do IVF. We put in a certain number of embryos. We'll freeze extra embryos that we have for people to use later. The longest time there's been between freezing an embryo. Let's say we froze. This is a real case. Freeze embryos from a woman doing IVF. We put in fresh embryos first. She gets pregnant, we freeze the other ones. The longest time between freezing embryos and siblings born from the same cycle, 17 years. Yeah, so sperm actually freezes really well. Embryos freeze really well, and eggs don't freeze so well. We're working on that one, but they are being frozen also now. Yeah.
Go ahead, Michelle.
I'm sorry. Confiscated Van Wheelay froze a container holding the Delzio's eggs and sperm. As far as the Delzios were concerned, Van Wheelay had committed murder. They sued him.
Yeah, well, it might have had to do with, and I think I have heard of it, it may have had to do with what he did with them or how he froze them or what he did. Did he just take them and stick them in a freezer? That's not going to work very well. I think that's what it had to do with actually not freezing it in a proper way for it to actually be preserved. Because you do have to do specific freezing methods in order to preserve any of these gametes and embryos.